Hi everybody, we're just waiting for the whole system to allow everybody in. We've got over 100 people joining us for this particular session, so just bear with us whilst we get everybody into the room and things. I'm Dr Gandalf. Hopefully some of you come across the stuff I put out on EGP Learning, but today we're here providing this session from the Practice Index team, and thank you to them for providing this really interesting session. I'm sure many of you are looking forward to try and understand how to tackle that 8 a.m. rush. You know, that whole concept of the fact we potentially got patients queuing out at the front desk, or, you know, waiting on the phones just for that to go from 7:59 to 8 o'clock and start dialing that number to get on the queue and stuff. And we're going to hopefully be looking at how one practice has been able to change the whole system that they had to make it so that actually that's not really much of a stress at all for them anymore. And that's going to be really useful, I think, as we move forward with some of the changes happening in general practice. Obviously, currently there's the new contract that recommends the use of a capacity and access improvement plan for many networks in particular that you will probably be looking at with your local practices in the next few weeks. Why? Well, the deadline for that's the 12th of May, so it happens soon. But in this session, like I said, we're going to be looking at various different things from one of our practices, St Lawrence Surgery, talking about how they've been able to basically change the demand capacity challenges they had and make it more manageable for both their practice and for their patients. Just before we hand over to them, a quick little reminder. So this session is being recorded and it's be available to use on the forum afterwards for people to have a look back and stuff. Additionally, we are going to take questions throughout this session, but what I would ask that you do is use the Q&A function on Teams to submit your questions. And the reason for doing that is just before you type your questions into there, just have a quick check and see if somebody's already asked it. And if they have, upvote the one that's already been asked, just so that it makes it easier for us to coordinate, and hopefully that means we can get through more of the questions that you want answered. We have got some pre-submitted ones that we'll go to and stuff. And just a reminder, we've got the feedback link coming towards the end just to get your perspective on how well this session has gone for you and cover the information that you want. So hopefully we've got everybody jumped and enjoying. We've got over 200 people joining us for this session, so it's going to be really interesting and stuff. So I'm going to get started. First of all, I'm going to ask David and Joe to introduce themselves. And just lastly, if you do have your microphones off, please can ask if you switch them off. Sorry, if you've got them on, please switch them off just so we don't get any feedback and stuff. Forgot that little bit of housekeeping, didn't I? But yeah, if I can pass over to David and Joe to introduce themselves from St Lawrence Surgery. Yeah, is that all right?
Lovely. Hi, I'm David Stokes. I'm a GP partner. I've been at the practice here for about 9-10 years now. And I've been doing a whole bunch of other things, including some support roles, turnaround roles and things, which we'll come to in a bit.
Hi, and I'm Jo Wadey. I'm a practice business manager here at St Lawrence. I've been here 16 years now, so showing my age, unfortunately. And I'm also director of the Institute of General Practice Management. So it's really fantastic to be here. Thank you very much for inviting us.
Thank you. And I know that over the past few years, both of you have been working at the practice in St Lawrence Surgery to basically try and make the whole demand and capacity kind of process just work as best as possible. Like I said, both for your practice teams, but also especially for your patients. And I guess that's been a bit of a journey. Can you tell us how you kind of started on that journey itself? You know, what made you want to change, and where were you when this first started?
Sure. So a few years ago, before the pandemic, I was working with a practice who were having some issues with CQC, and they were working through their challenges. And as part of the some of the things that they brought in order to give themselves some breathing space to be able to make the changes that were necessary, Fitzallen practice I was working with had this great idea of putting one of their very efficient GPs sort of co-situated with the reception team in order to sort of safeguard the precious appointments that they had. I think it's an idea which has been tried various places in terms of A&E. You'd often ask about putting the most senior person on the door to try and manage this demand. And they implemented this change. And as an observer, I could see the incredible change it made to their capacity and demand. And then coming back home, I could see that although we weren't quite so pressured initially, the fact was we still suffered with that please call back tomorrow disease that so many practices struggle with, which leads to an enormous amount of unmet and unknowable demand sitting there in the system as patients are being asked to call back again tomorrow. We were doing an awful lot of telephone triage, trying to deal with the emergency demand on the day. And I could also see, just anecdotally, that now we work with so many more different clinician types, so AMPs, paramedic practitioners, pharmacists, etc., that quite often patients were being booked in with not necessarily the most appropriate person first time, and that in itself was leading to a huge amount of duplication of effort. So you were getting people seen by one clinician who then said, well, actually, you don't need to see me, you need to see someone else, and that's 2 appointments used up instead of 1. And so as I could feel that pressure building on us, I decided to talk with Joe, and we looked at making the change in our own practice.
And then as you started making that change, how did that develop into what you currently have now then?
So what we currently now have is a doctor or a paramedic practitioner or a nurse practitioner in the office all day with the team, and we've got some photographs to show you, but basically the calls come in and everything is triaged by that prescriber that's in that room. So they will either they will make a decision as to who it's best to go to, whether it's a face-to-face, it's a telephone, whether it goes to a different practitioner, whether it goes to the pharmacist, whether it needs to be self-help, and some things that they will do there and then as well. So, you know, if somebody needs a quick swap in medication or something like that, it can be done. So so that's how we do it now.
Yeah, well, I guess in terms of the journey, though, there was taking any practice to a completely different system for managing their workload demand, and there've been lots of different iterations of this, these sorts of changes over the years, from Doctor First to all these other sort of models which are out there. It is a big change management program. You need to take your entire team with you, and in order to do that, you need to have a very clear vision of what that might look like, the benefits that the entire team will have, and then how we are going to move to this new system. So we actually worked quite hard as a team, both myself and Joe. And
change management program.
Yeah, we worked through the program, and involved all of the important members of the teams to come together to sort of design how it would look for our practice.
Okay, so when you kind of started on that journey, like you said, there was that whole change management process that you went through and stuff. How did you sell that to the practice teams? Because whenever you do any kind of change, it's always potentially overwhelming for people, particularly when, right now, obviously general practice is, let's be honest, chaotic at the best of times. So then having to look at a change process again, that can sometimes be really obviously overwhelming for members of the team and stuff. How did you approach that kind of process for your particular practice when you started it?
We got all the relevant people in the room together, didn't we? And we talked about the current situation as it was now, in the fact that the receptionists were feeling really, really abused. The fact is that, the patient would say, well, I phoned up now 5 days on the trot at 8 o'clock in the morning, and you'll still say my doctor's not available. So we had all of that situation. And then we had the doctors that were just having lists and lists of phone calls, which were, and they called it, triage is the monster. And so it was very much about sort of being able to explain what happened at Fitzalan Medical Centre, and actually saying we could adopt this. Yes, we tweak it because our clinical workforce is different to Fitzalan. But how is it that, if they've made it work, how can we make it work, and how can we make it work for us? So there was lots of conversations around, how would you like to see it work? And we had to tweak it constantly, but it was a huge leap of faith. I'm not going to lie, it was quite hard, wasn't it? And there was lots of conversations around the receptionists feeling they were going to become de-skilled, and the doctors were wondering about how were they going to cope with all these people putting their hand up and asking a question. And we had to work through all of that, like you do with any change management, and take people with us, which luckily we've got very open-minded staff generally, and they were able to trial it, because it wasn't great the way it was. So let's try something else. If you keep doing the same thing and you're getting the same results, let's try something different. So
yeah, I mean, I think to start with, it was quite easy to frame the problem. I don't think anyone in general practice is going to be sitting around saying, God, I've got so much time on my hands, I'm not feeling at all stressed by the workload and demand. So that bit was easy, showing people that there was a problem was no problem. But then, being able to show them a vision for a solution, and then being able to show them how that could change their lives, at that point you get the buy-in, and then it's a question of working through the potential challenges that there are to it, and again, making sure that the key people are involved in any change.
Okay. So I can see there's a fair amount of stuff coming through in the chat. I guess what would probably be useful is covering some of the nuts and bolts of I guess your team and your practice and stuff. I know you've got that on the presentation, so maybe worth us having a quick look at that. One thing I would like to remind our 200 plus members joining us, for the questions, if you could use the Q&A function rather than the chat, it just makes it a lot easier for us to manage that when we come to answer your questions and stuff. So I know loads of people are sticking things in the chat. Please, I'm going to ask you to stop and actually put it on the Q&A section instead, because it allows us to just manage that so much more effectively. And we are going to cover, I think, a lot of your questions that you've already asked so far in this. But yeah, take it away.
To interrupt, but I'm just going to say I can't get into the. I've been trying to get into the Q&A bit, and it just says there was a problem reaching this app. I don't know if it's just me or whether other people have got a problem, but that's why I put it in the chat instead.
Okay, all right. I think I've got quite a few questions already come through in the Q&A, so unsure why that's happening, but thank you for that.
Okay.
Yeah, so Dave and Joe, if you want to carry on.
So just a few stats. I see lots of messages popping up about how many patients have we got. So we're in Worthing, West Sussex, right on the coast. We've got 16,000 patients. We're a very large training practice. So we always have at least 4 or 5 trainees at any one time. 6 partners, 4 salaried GPs. We've got 3 paramedic practitioners and 2 nurse practitioners, 3 pharmacists, 2 of those are prescribers, and recently recruited a physician associate as well. So a wide skill mix actually across the practice, which makes that nice and easy for us, or easier for us as well. And just to we got outstanding for CQC in 2016, and we managed to retain it. Because of this signposting, because we were able to actually show that there was an impact on our patient satisfaction and some of the statistics. Just to show you really quickly why, we've already talked about that, so I'm not going to go over that again, but patients been asked to ring back time and time again. And then this is what happens. We've got Dr Stokes there in the background. So they're all sitting around there, and they literally take a history. Why is it that you're phoning today? What's the nature of your call? How long have you had it? Who have you spoken to before? So then they put the phone on hold, and then they speak to the doctor, who wanders around to each one of them and has a look at the medical record and makes a decision. Yeah. This is just to show you a screenshot of EMIS. So these are the questions that we ask. If then they turn around and say, well, we're really struggling with our mental health, and this is what's evolved over time, we'll go on to the mental health pathway. If they say, well, I've got a UTI, we have a UTI pathway. So there are certain pathways that we have actually developed as we've gone along as a team. And there's red flags issue there as well. So that's just to sort of show you that that's not all of that on there, but that's just sort of the first screenshot to show you that they have a template which they fill in, a bit like 111, but not quite as detailed. And then when the doctors are making a decision, or the paramedic practitioners or nurses, we always normally only put prescribers in there. They actually look. So say, for instance, they think, well, no, actually that appointment needs continuity of care, and that doctor is back from holiday next week. They can actually look ahead and see where most of the GP appointments are, or paramedics. So it's not rocket science. It's nothing very pretty, but we literally run that search every day for sort of 3 weeks ahead, just to sort of see. So they would look and go, okay, well, it looks like there's lots of GP appointments on the 24th, there's 55, we'll take one of those, etc. So they've got a bit of a forecast of what it looks like. So on the 2nd of May, that's the day after a bank holiday, we've blocked the GPs for that day, actually. So we wouldn't book any GP pre-book appointments on that day. I hope that makes sense. Telephone system, a new telephone system coming in. We can talk about that later in sort of our next steps, really. Is it worth talking about that, Gandhi, or just that bit there?
Yeah, I think there's probably going to be lessons that you've already learned by going through this process. So yeah, probably worth sharing what you found out so far with going through that process over the past year or two.
Yeah, so First of all, we decided it definitely wasn't right for a GP or a paramedic practitioner or anyone to be in that room all day, because I think there's only so many hours of brain decision making.
You'll get decision fatigue. It is fairly full on, and you need to learn when you need to swap your clinician out. I think that's key. There's some other sort of niceties there. So, for example, it does really help bring the entire team together. GPs no longer feeling always isolated in their own room, not seeing anyone else. You've got the reception and patient services team who feel supported and able to work with things. And one of the things is it's quite clear we've got quite a flat hierarchy in the practice, but it wouldn't be good to have a doctor who thinks of themselves as the god going into the reception area and dictating the way everything should be. There needs to be a lot more give and take, and we're very good at that. My reception team, they know very well that if I'm getting stressed, I might get a bit sweary, and they've got permission to tell me to take a walk, and they'll swap me out for someone else. And I think that sort of thing is really useful for longevity and preventing burnout of the team members, which is important.
Generally, the doctor starts at first thing in the morning, is swapped out a coffee, paramedic practitioner might go in, or another doctor, and so there's this sort of every 3 to 4 hour window, I would say, that someone is swapped in and out. Clearing the clearing the unmet demand, that was always the scary thing. It was like, well, how much demand is out there that we don't actually know, that we haven't actually been able to service? So it's very much about having faith to pre-book your appointments ahead, because people always say to me, oh God, if we pre-book everything ahead, what are we going to do on the day? And that was the scary thing for us, but it really does.
You need to have a bit of faith in the fact that this is going to save you efficiency in terms of not having those people bouncing back to another clinician. You're going to be able to increase your continuity of care by booking patients in with someone they've seen about this problem before, which is clearly more efficient, and it's what general practice has done for forever. And we lost a bit as it all got horribly busy and people's working patterns and things shifted. It's the fact that the person on the front desk, because you feel like, oh my goodness, I'm going to lose a frontline clinician for an entire day doing this role. How am I going to fill the slots that they're not providing on the day? Well, again, a lot of the stuff you're going to be able to deal with very, very rapidly at the front desk. So, for example, if I'm getting someone calling in with lower urinary tract symptoms, and I know that they're going to need a urine dip and possibly a PSA, dependent on what I've managed to think, I'll get the investigations teed up before they're seen by the clinician. So that again saves probably an entire appointment. There are so many little efficiencies that you make by making these changes that you do increase your capacity way more than what you lose in terms of the clinician on the front desk. But there is a lot of faith, and we had, going into this, our eyes wide open. We did a lot of work with Joe's brother-in-law on data. We looked at our appointment data. We looked at the number of people who were coming back. We looked at the telephone data, seeing the number of people who were calling day after day, and we saw the people who were being booked in with one type of clinician and who were then subsequently having another appointment. So we had a huge amount of data there. And we also used the whole change management process to build in some data collection as we were going through, so we could see, well, what would our ideal skill mix be in practice? We could look at when a patient was being booked an appointment, well, what would be the ideal clinician to see this person if we had the availability for that? And all of these things give you a really rich set of information to be able to build your systems out from there.
Yeah, absolutely. Just to reiterate that was amazing. So when you got to the end of the template and it's saved, it would pop up and the receptionist, and it would say to the receptionist, where did that patient go to? Was it a GP? Was it a paramedic? Was it a nurse, etc.? And they'd tick and they'd say, where should it have ideally have gone to? And from that, we were able to map what we felt our skill mix should be, which was really, really helpful.
Yeah. Okay.
And then
so,
the whole, sorry, carry on.
No, go for it.
I know, I was just going to say, and then just as David alluded to, really, we were able to realise there's quite a few common reasons why patients phoned, and then we needed more information or a pathway for it, which is where we developed all of that. For instance, the UTIs, the GPs didn't always have to get involved in unless the pathway sort of flagged that to them. So we learned quite a lot about the amount of times patients phoned for the same reason and how we could direct them.
Mm-hmm. Okay, so let's go a little bit more into the nuts and bolts of a few quick questions, if that's all right, because I can see we've got some questions in chat. So I guess with that, does this mean that the GP is triaging all of the calls that you get? So that's one of the questions that come through in the chat. So, you know, however many calls you've had, is that clinician, that prescribing clinician, basically having contact with every single patient or not?
So we don't triage directly things which are sort of booking into nurse clinics, for example. We don't deal with sort of admin questions, blood test results. So some of those calls will be dealt with directly by the patient services team. There's obviously that initial how do you deal with that rush to start with, and you know, when you haven't yet trained your patients that no matter what time they call, their problem is going to get dealt with, you do still have that that initial rush, and you need to plan for that. So certainly in the early days, we made sure that during the rush we had enough clinicians sort of around at that point to make sure that the reception team were not waiting too long for an answer. There are various little tweaks like that, which are, you know, they make a big difference to everyone's success. If you roll it out well, it'll go well. If you don't think these things through, you could come a cropper.
Yeah. That's a really good point, actually. First thing, he's right. It was a rush at 8 a.m. and it was too much for one clinician. So we had 2 or 3 in there, but we don't need that anymore because they know that they can get to an appointment, which they need, not what they want, they need any time of the day. So.
Okay. I think you mentioned these 16,000 patients. Is that correct for the practice list size? So can you give us an idea of context of how many calls would you typically get throughout the day then?
Well, on a Monday, probably about 500 to 700, and then during the week, really about anything between 250 and 3, and that's gone down since we're not getting multiple calls. So we were able to show that to CQC in our impact assessment report that patients aren't rushing to phone at 8 a.m. in the morning, and we're not getting multiple patients phoning, or the same patient phoning multiple times. So yeah.
Sure. And do you have an online consultation route as well coming into the practice? And if so, roughly what are the numbers in comparison?
So e-consults were something interesting. I was quite keen to see come in when we first brought this in, because I felt it would be a better way of asynchronously sort of getting the information we need and be able to sort of sort through them afterwards. There is always the argument that it's an open door, and you know, as you open more doors, people will find reasons to contact us. We locally have got an e-hub which was commissioned locally, so we work with the other practices in our PCN on our e-consults, and they are limited to a certain number a day. I think it's 25 a day or something at the moment, but that's been something that changes quite frequently.
We were doing up to about 50 a day. Yeah. We'd have that allocated.
Okay. And I guess in terms of you mentioned the skill mix. Obviously, you've got a variety of skill mix clinicians. You mentioned the paramedics, the pharmacists, the PA, and that kind of stuff. How have you approached explaining that skill mix to not only the patients, but also, I guess, with the clinicians, understanding the capabilities and limitations of what they may be able to cope with to make that process so that you do get the person with the right person at the right time, kind of thing?
Yeah, go for it.
So we it's really helped with our GP trainees as well, actually, because obviously we've got our GP trainees. So I mean, we used the most senior doctors because they knew the skill mix and who could do what, and then they've continued to train the other doctors as a result of that. But the patients are absolutely fine. They don't seem to mind who they're seeing anymore. They just know they're going to see someone. We don't ever seem to have had a problem with that. You get the odd one that says, I only want to see Dr Stokes, but we can, you know, sometimes that's appropriate, and sometimes they will only see Dr Stokes. But you know, so I don't think we've had a problem with it. What I do think is it's been much safer. So the caseload for our physician associate and our GP trainees and our paramedics has actually been much much more relevant, much more appropriate, where before the receptionist wouldn't know what a physician associate did versus a paramedic practitioner. So I think it's improved that a lot, actually.
I mean, there are other advantages to knowing, you know, what your clinicians are able to do, in that you can book patients in with a particular problem with a clinician who has a particular interest or ability to deal with that problem, again saving potential appointments. So we do have a resource that we have at the front with all of the patient services teams, knowing what clinicians will see, what their cut-offs, what things they're not comfortable with, and that's quite a useful resource for them. But,
and sorry, each of our paramedic practitioners, nurse practitioners, physician associates all have a mentor as well. So with our recent physician associate, they will talk to the mentor and say, I'm not really very comfortable with mental health, for instance, and then that would be fed back to the signposting team. And then obviously that raises training and development issues, but also making sure that they're protected from the cases that they don't want to see.
And I guess when you started that process with patients, for example, what kind of extra workload or kind of process did you go through to support the patients with this whole journey, in terms of understanding the changes within the practice, you know, what the outcomes are going to be? I guess even simple things like potentially the patients may be waiting on the phone. Is there anything specific you're doing to help them understand why that's different to before?
We did a big communication plan. We've got a really active patient participation group, and so we involved them, and they were there at some of our planning when we talked about our change management program. The patients were there for that as well, so they were very good at sort of getting the message out in the community. We've got a Facebook page with about 2,000 or 3,000 patients on it, so we did it through that. We did it through the website, as many ways as you possibly can, really, to actually try to explain it. Because you're right, to start with, you know, it's a bit longer on the telephone, because they're getting a decision and it's dealt with there and then, so it's not that fast. Sorry, we haven't got any appointments, phone back tomorrow. We were actually dealing with it, so we were able to sort of say that on the phone message, that we were implementing a new system. You will get the appointment that you will need, please wait, it might take longer to get through. So every way we possibly could, we did that, and I'd be happy to share some of that with people.
Okay. I guess when you had this whole process, you mentioned obviously the kind of like rota aspect. You had a clinician doing that, you know, triaging kind of perspective for a few hours, and they swap out and stuff. How does that kind of work with the rotas? Because I guess there may come a point where somebody says, oh, I just need, you know, 10 minutes. I need a break. I can't do it today. I've hit my limit. How does that balance, I guess, with the rotas, with the other side of it, in terms of the people seeing the patients and that kind of thing? Could you explain that to us?
It's interesting. I mean, I still remember when we first brought it in, I was thinking, how am I going to go to the loo? Because if I go to the loo, then I'm going to have sort of 5 or 6 patient services people hanging on the phone with irate patients wondering what to do. But there's a few things. Firstly, at this point now, some of our experienced patient services managers, who we have managed to hold on to much better than before, because they are no longer getting shouted at nearly as frequently by irate patients. They know better than me what is available or who sees what, because they have the experience of hearing a number of different triage clinicians advising on things. And again, I would advise everyone to listen to their team, because they often do know best. So sometimes they might hold the fort if the phones aren't crazy and someone needs to go away. However, our structure always allowed us to have a second GP as part of our duty team. This predated our new triage system, whereby we had one person who was duty dealing with the emergency stuff, and another person who was dealing with all of the administrative, you know, prescriptions, results from people who weren't there, documents, urgent requirements there, covering the trainees and things as well. So we are lucky that we have a degree of flexibility within the workforce to change things around, but we also allow it as a change from people's routine. So having, for example, our nurse prescribers or our prescribing paramedics, having them come in and take on a portion of the time when it's perhaps not quite so busy, frees up the duty doctors to, you know, get the head clear and get on with, you know, some of the other tasks and work that needs to be done.
Okay. there's a few questions that kind of talk about the theme of signposting, and obviously, has this kind of system affected the way for your patient services team to actually manage independent signposting for patients, or has it supported them in terms of doing that?
Well, certainly, for example, the referrals to community pharmacy, yes, it absolutely does. But I'm quite often the one who's being nudged in the ribs by my guys on the telephone saying, "If you thought this one might they not just be able to go to the pharmacy rather than taking up a paramedic appointment?" And you know, they're generally absolutely bang on the money. So yes, they are good at that sort of stuff. Also, quite often with a clinician there, if you're able to take enough of a history to make yourself comfortable with the situation, you're able to appropriately reassure a patient over the phone there, because quite often what they want is not necessarily an appointment, but they want reassurance that, you know, what they've got isn't dengue fever or something horrendous. So there are ways of appropriately dealing with things that don't even need a telephone call from a doctor.
Yeah. Our reception team, I remember at the beginning, were a bit put out and saying, well, you know, you're de-skilling us. You know, we know where these patients are going to get booked. So we had this sort of little fun game that we implemented, didn't we, where we say to them, okay, well, when you've taken the history, write down on a post-it note, a bit of paper where you think that person should be, and then let's see what the clinician says. And we'd have a bit of a sort of a laugh about that, wouldn't we, really? And sometimes the doctor was right and sometimes the receptionist was right, and it was quite nice because it meant that they started to work together really well as a team and value each other's skills, really. So
And I guess, how do you manage, if we're going to look at this from the clinician's perspective, I guess, how do you manage that anxiety that people may have in terms of, for example, you know, a headache can be anything from a simple tension-based headache to cancer, to that kind of, and obviously the amount of information you get will vary based on the patient services individual and the way they ask some of those questions, even though they are templated questions and stuff. So how do you manage that anxiety within the clinical team and making sure they get the best information possible?
So this is there's learning everywhere. The patient services team, when they first come to it, are not going to have any experience of asking any sort of clinical history. So they need to have a bit of input and a bit of training as to how to ask these questions of the patients. And prior to that, the patients need to have been prepped, preferably either by having been trained in the practice or having the phone message warn them why they're going to be asked these questions, and it's not just because they're being nosy. They need to know it to get them the right thing. Two, the clinicians, you know, there's going to be a wide variety in terms of anxiety or ability to manage that sort of risk remotely without them having got involved and asked the questions. There is obviously scope for the clinician to ask the reception telephonist to ask subsequent questions. However, we've got to be quite careful with this, not to get into a consultation by proxy. So I think we've spent a lot of time working on that and feeding back to clinicians who are working in that way. This is not the way to do it. There is always the safe way. If you are not sure, you at least put them on the list for a phone call so that the clinician can call and make that list. It doesn't work out that actually that many need to go onto that, because you can generally make a good decision with some very basic information about, you know, is this someone who needs to be seen face to face? Is this someone who's going to be needing at least a phone call? And who is it going to be best for them to be dealt with? So I think, you know, it's a progression. There's training on both sides, and it's about making sure that you are comfortable working within your limits. And I think that the thing that we did with our bringing this in, we spent a lot of time planning the implementation. As with all change management, communication with everyone can never be done enough. You will think you've communicated it to death, and people you will not have communicated enough with the different members of the team. And regular assessment and feedback on what's been going on. So we
had lots of case scenario meetings, didn't we? Well, what would you do in this situation and that sort of thing. So I think in some ways it's safer than the receptionist deciding whether it's a doctor or a paramedic or a phone call. You know, at least And so with the new telephone system, we're hoping that with all the rights and the privacy and everything ticked off, that the doctor will actually be able to listen in if they want to that conversation and ask the receptionist to ask more follow-up questions. So we're constantly tweaking and advancing it, but touch wood, we haven't had any serious incidents as a result of implementing it.
Okay. And how have you kind of prevented that concept of somebody jumping in? Because I can, if I'm thinking about my potential perspective of how I would, I can see myself, trying to take over every call and stuff if I'm not careful. So how have you tried to tackle that in a worry or anxiety from the clinicians to not just end up taking over, and it end up then being obviously a consultation, which then obviously impacts the other 4 patient services members waiting to get advice and stuff?
I think certainly from the clinician standpoint, they can see the telephone board as well as anyone else. So there is a degree of time pressure. They can see what the wait times are on the phones, and they don't want to contribute to that. And
the hands start going like this, faster and faster, to attract their attention. So there's that pressure, isn't there?
But having an open and honest relationship and being able to discuss with the team, the feedback from the reception services manager, in a safe way, so that people aren't feeling threatened in their professionalism or what have you about the way they deal with things. I think that's a really helpful way of getting over that.
You're always going to get more experienced, more confident doctors, and it's good for them to start it, and then the other doctors that are less confident shadow them. And then, and that's what we did, didn't we? Lots of that sort of thing. Well, okay, well, if you want to do this, David, you start and we'll follow. So there was some of that as well. There's always the braver ones that will start and the others that can come later on and shadow, really.
Okay. I guess if we go back, for example, about a year ago, this was when, round 4 or whatever it was of COVID was going through general practice. And obviously there were various points where staff were having to go off sick again throughout for either isolation reasons or other kind of reasons and stuff. So that would have obviously impacted the staff that would have been available to primary care. I guess, how does the system work when the practice is facing a point where the normal workforce in the practice has suddenly dropped? I mean, clearly, if that was to happen at a holiday period where you're typically a bit lighter, suddenly 2 key people are off sick. How has that responded to those kind of challenges? Given the fact it sounds like the system is very much based on the practice teams being there and possibly less resilient to having a new workforce coming in, something like locums and that kind of stuff to support and things.
So I think if you're working with locums, it's the same. You've just got the resource which you can see available to you. You just don't have as much of the option to get the benefit of the continuity of care. Sure. I think the other changes that we have seen over the last few years have seen significant improvements which work well with this system. So Accurix is fabulous for us, being able to get photos of people's throats and sending them links to Gandhi's video about how to take a good photo of a throat and things like this. That works very well in this sort of context, because again, you can get the clinical information you want, because you can ask the patient services manager, I need this, this and this. Get them to do that, put them on triage, and then the person going through the on the day demand has got a much better chance of getting through things. Being able to work remotely, again, it works nicely, because if more things end up on your telephone triage list, well, if you've got people who are isolating but able to work from a computer list, well, they'll go through some of the remote stuff. It works well because the flexibility is supported.
We've never removed a doctor from signposting and not had anybody in there as a result of that. That's our priority, to have somebody in there, because we think it's the most efficient way of dealing with the demand on the day. And as David said, we wouldn't get a locum to do the signposting. We'd have the locum doing the clinic. So. Okay.
At the start, when you kind of started this process, how long would you anticipate a rough call to last? I mean, if we're talking about the journey of that particular patient, you talked about potentially sometimes they're on hold and that kind of stuff. On average, how long are we talking about where a patient would be on the phone for?
Ooh, that's a good question. But yeah,
it's 2 to 3 minutes. It's just over the 2 minutes, so which I thought was really good, actually. Thought it would be a lot longer than that, but that telephone stats show on average 3 minutes per call.
Okay, and it sounds like you've got a fairly broad team, obviously in the practice. How could you see this working for example, practices much smaller? You know, say for example, one GP, one A&P, and one paramedic, versus much large. I know we've got practices of 25,000 patients plus. Hub working, I guess, sometimes comes into that. How do you see it? And appreciate that's obviously asking you to extrapolate what you're currently doing to other situations, but if you're offering suggestions of given the experience you've been through, what would you be thinking about?
I'm sure that this system or a variation on it could work for most size practices. I suspect when you get very small, the very small practices, well, they often cope quite well anyway, because they've often got more continuity. The patients often, in my experience, are better trained. I don't know if we've got people on the call who would disagree with me, but often the smaller practices wouldn't need so much this, because their patients are a slightly different behaviour to it. You might not, in a slightly smaller practice, you might not get quite so much benefit if you haven't got that broad spread of different professionals, but still I think that the number of things that you are able to deal with at the front door, so to speak, of general practice, it more than makes up for the time you take out of the clinic. I can't imagine it working for a single-hander though.
Fair enough. I think that's probably a lot to ask them to do, isn't it?
Yeah.
The new contract has suggestions about booking patients, 2 weeks in advance and stuff. How do you anticipate that having an impact on your current system? Is it going to change what you do?
I mean, I think, again, we already do. I suspect we're pretty much there in terms of our access anyway, because of this system. As with all these things, the devil will be in the detail in terms of how they measure or what they expect. But the patients will generally be booked in within 2 weeks, three at a push. But again, if it's 3, it's because they're after a specific individual.
You might be on holiday.
Exactly. Yeah.
Mm-hmm. Okay. We heard about obviously that journey of patients ringing the practice and stuff. What do you do for those patients who, for whatever reason, can't ring? So I guess I'm thinking about the ones that find tech really challenging, the non-English speaking, learning disabled patients, or those just who want to come into the practice no matter what.
We have a paper template of what they ask on the telephone at the desk, so we try to discourage it, but if there is anybody that really needs to, exactly as you've described, we will ask them and we will help them fill in that paper template, and then that will go into that signposting doctor, and then they'll decide where they sit and wait in the waiting room. It
was really important to us actually when we instigated the changes in the first place, that equity of access was sorted. That was the way round we did it, but again, it was partly because we were struggling with, I suspect, something that a lot of the practices on this call struggle with, which was a queue out of the door at 8 a.m. with people thinking, if I don't get down there now, I'm not going to have a chance of getting one of the appointments for today. And again, within a week or two of starting this, the numbers just dwindled to almost none, because they realised that they were going to get what they needed over the phone.
Okay. So I guess just to clear off a few questions we've had in the Q&A and in the chat, I'm just going to cover these, and please correct me if I've got this wrong, David and Joe. So you're a 16,000 patient practice based over one site, EMIS based, using eConsult as your online consultation platform, and you typically found that you're getting about 500 to 600 calls on a Monday morning, and about a couple of hundred on the other days throughout the rest of the week. Is that a good, very brief summary of what we've covered in terms of your demographics? Because I'm just aware we had quite a few questions repeatedly asking those. So does that sound right?
That does sound
right.
Yeah, right, definitely.
Another question we had was about the number of GP sessions you have throughout the practice. Now, I must admit, I hate the concept of sessions. I think it's one of the reasons why general practice is struggling so much. But I guess if we were putting a number on it, what would be your average GP-based sessions that you have in practice, noting the fact you obviously have quite a broad skill mix within the practice as well?
And can I come back to that in 2 seconds? Let me quickly work it out. I think it's about 45 to 46, but I'll check it out.
Fine, no problems. Okay. So I guess with the various different things, we keep having a similar question coming up about, do the GPs triage all the calls? David, could you just briefly summarize the kind of the difference between all the calls and whether the GPs, do contact them all and stuff? I mean, just where we keep having those questions.
Yeah.
So maybe we'll just summarize that in a minute
Sure.
whilst Joe's calculating the sessions.
So essentially, if the call coming in is a clinical request for some input with a non-nurse clinician, then the receptionist will take the brief history and flag it to the clinician who's duty in the office. So that is still the majority. It's certainly early on, it's the majority. They can book into our nurse clinics separately, or there is a nurse triage list as well that they can book into. They'll deal with a lot of the administrative calls. So some of those calls will obviously be people calling for blood test results, etc. And then again, there's a whole bunch of stuff we could talk about with that, but that's beyond the scope of this. But there are calls for those sorts of things, which of course the GP is not going to have to get involved in at all. But anything else, the GP is likely to be flagged to and just at least very briefly check whether the response is appropriate for it.
Sorry, going back to that, 56 sessions, but don't forget then that's only GPs, and then don't forget, and you've got trainees on top of that, but also those 56 sessions, then 10 of those sessions will be taken away for the signposting doctor and we call it the second on-call doctor that does the admin and the covering the trainees and the backup. 20
then, isn't it? To get taken off that because of the first and second on-calls. Yeah,
so you're down to about 30 to 36 actual clinics.
So obviously you'd have one clinician doing the triaging stuff and one clinician doing the other kind of on-call stuff as well in parallel. Is that correct?
Yeah, absolutely.
And then you've got the tutorials and goodness knows what. You wouldn't get as many as that. And then someone's on holiday. But yeah, that's basically it.
Okay. We talked earlier about demographics. I guess what proportion of your patients would you say are non-English speaking, and that could obviously include patients with other communication challenges and stuff. And how would you suggest a practice that had high proportions of those could tackle some of the challenges that they would present with this kind of system, which is very much audio based, obviously, in terms of contact and stuff?
It's a really good question, and it is difficult. I'm not going to pretend that we're nearly as challenged in that area. I don't know is the answer to that one. I think that it is a difficult one. I think perhaps moving more towards the tech for those who would be tech enabled, but language might be more tricky. If they've got other staff members who are able to help with languages, that might be an option. But I think it is a challenge for those practices.
And maybe speak to the ICB about the translation services, because you can get somebody on the telephone as well. So what sort of services are out there maybe that you could use translation on the telephones? But I don't know. Sorry, I would imagine that's a good piece of research work.
Fair enough. What has this done for your staff retention?
A lot better. I can't tell you a lot. We've got a very settled patient services team down there now. I would say that department is the highest turnover still out of the entire practice, but we're doing a lot more to tweak it. But certainly that has made a huge difference because they're not having to say phone back tomorrow, phone back tomorrow, phone back tomorrow. They're literally being able to offer them something, and as a result of that, there isn't any abuse. And if there is, we're very quick to jump in, but it's next to none now. Second, we don't hear anything really, do you?
It's a rarity, whereas it was an everyday occurrence. Yeah, absolutely. But I think it's good for all the teams. Paramedics who are doing it, they enjoy that variety in their role, so they're not just they're churning through consultations all day. GPs don't feel so isolated. It's really good for sort of bringing the practice together. So I think it's been really positive. It's good
team working for everyone. Someone asked up about GP trainees. When would you get them to do it? We wouldn't probably get them to do it until right at the end of their ST3 type. We wouldn't get F1s, ST2s, etc. doing it. Probably be right later on in their ST3.
But that's not to say that they wouldn't be involved. We've had some amazing suggestions from some of our trainees coming through that have made major impacts to our to our pathways and things. And again, it's often the sort of you can get them doing some of the improvement work or the audits and things that they need to do for their training, and they can be really beneficial to the system too.
What kind of training have you put in for the practice, so more for the clinical team, the clinicians themselves, in terms of that whole concept of triage? Because I think when COVID came along, a lot of people assumed that everybody knew how to do triage, and actually triage itself is obviously a skill in itself, and an independent skill, particularly when you're doing through either phone or video routes and stuff. So was there any additional training you put in, and can you give us any ideas of what that might have been if that was the case?
I don't think there was any formal triage. It's much more shadowing, and each of our salary GPs and all have a mentor, so which would be one of the partners. So you would have like mentoring sessions with them, and we would have case scenario type conversations and shadowing, but nothing formal.
But interestingly, it's also been the case that often some of the more experienced GPs have learned an awful lot from the newly qualified GPs coming through, who seem to have been brought up much more in the era of telephone triage and managing things remotely in this way. Actually, some of our most effective guys on the front desk are the guys who've just come through the system now, and we're constantly learning from them the ways that they cope with things, which is not always the way. Often it takes a while to sort of feel your way into general practice once you've passed your driving test, so to speak. But these guys are doing really well.
I think we've got a couple of doctors that work sort of GP and A&E as well, and they seem to be really good at it, don't they, as well?
So I guess a couple more specific questions. What would you do in the situation where a patient point blank refuses to engage with the process, that they just don't want to share any information at all? It's just not going to happen.
We do very rarely get that, and we just say, okay, we're going to get somebody to phone you up later, and we put it on the triage system, and then someone, their GP, will phone them up later.
Okay. And the situation where you want a patient to be reviewed, say, for example, in 4 weeks' time, how does that work? Does that work differently to this? Is it that all your demand comes through this route, or is it a separate mechanism?
No, I mean, it's not. It's not a letter of law. We haven't turned off people's ability to book appointments and things. It's there's a degree of trust. People know that it's going to work, and if a clinician feels they need to be seen in 4 weeks, they need to be seen in 4 weeks. So we'll get them booked in if the appointments are already on the system.
Yeah, that's what any follow-up ones, definitely.
And what's your DNA rate like from that perspective?
Pretty low.
It is low.
I mean, I don't see the DNA necessarily as being a horrendous problem. Two reasons. I've never sat there on my thumbs thinking, what on earth am I going to do now? I've always got something else to do. Plus, with this sort of system, if you found yourself with the DNA, you can dip into the list of triage work that needs to be dealt with that day. And again, because everyone does feel like part of such a good team, people are desperate to try and make sure that things work, and we'll pick these things up.
I think it's definitely low. It's higher for the nurses that we're booking 3-4 weeks in advance for a diabetic check or a smear or something. They're the ones that we get the high DNA rates for.
And when it comes to adding, I guess you've got a list somewhere. Yeah, when these calls are coming through, is that a list on EMIS? Is that a list on e-console? Logistics. How does that list look to somebody looking at it?
So it's an EMIS list. You can cut it how you want. We have it under the name of the named doctor of the day, and we will use that to capture everything that needs to be done, from the requests for some prescriptions and things which come in as an urgent, to the patients that need to be spoken to but not booked in for an immediate appointment.
We have a list for medication queries that goes to the pharmacist, and we have a list for nurses, don't we, for sort of more nurse things like wanting to book a coil and things like that. So and then we have a doctor list which the paramedics dip into and the nurse practitioners dip into as well.
Okay, so we are coming towards the end. I've got a few more questions still to go, so please don't jump off everybody before we do that. However, I think Jill's going to put the feedback form in the chat, so if you could fill that in whilst we're getting through these last few questions, and they are really important ones. So one in particular has been a question about the phone system that you use. I know that there's some changes you're planning. Can you tell us about those changes, and also the kind of phone system side of things that you mentioned earlier?
Yeah, of course. So yeah, we have got a phone system at the moment, but we are moving to something called Think Healthcare, which is just a company that I'm sure it's the same with a lot of them, that have a lot of extra features, like you can put numbers in for patients for VIP. So if we're concerned about patients having to wait a long time in their palliative, you can put that in the system. And this new system will allow us, once we've sorted the privacy out, etc., will allow us for the doctor to be able to listen in on the patient talking to the receptionist, so they can jump in with more questions and listen as well. So if the patient had bad breathing or they were concerned about the pain, they might just want to quickly listen in as well. But at the moment, it's just a very normal phone system. The new one will also have a callback scheme, so that they will be called back when it's lower in the queue. But at the moment, it's just a very normal system, really. Not I can say about it.
That is something which would potentially be very useful, because inevitably this will increase the length of time some people are going to wait on the phone. There's no question, but we know that they're generally happier because, having waited on the phone, they're going to get something, rather than getting to the end and saying call back tomorrow, which is the worst of all worlds.
Mm-hmm. Okay. You mentioned about well, actually, we've had quite a lot of questions asking about sharing of resources, templates, the kind of the very stuff that you have and things. I'm going to cover that in slightly different sections. So the first was there was a question about the promotional stuff that you had in terms of how you onboarded the patients, how you advertise it and stuff. Is that something that you're able to, I guess, share that particular side of stuff in terms of the patient promotion side of it?
Yeah, I'm very happy to work with Practice Index, and we could collate all of this information together and have some sort of resource pack or something that we could send out. That'd be fine.
Mm-hmm. And I know there's been more specific questions about some of the clinical templates and the other kind of content that you have. Can you tell us a little bit more about those resources, if that's okay?
I mean, we've developed along our way sort of the templates, etc., and we've done sort of training with our patient services managers in terms of their training and things as well. A little bit nervous about sharing those in terms of the way they might be used without thought being applied. So rather than sharing specific templates and things, I think I'd be happy to share, for example, principles that you might like to look at when you're developing your own resources in-house. Just so that I think this is a very. I'm a big advocate for it. I think there's a lot to take on board and to think through. I'm just developing a course that might be useful to some people to gather together all of the information they might need, and I think we might put a link in the chat to my newsletter, which will keep people informed of that and share some of those resources.
Mm-hmm. And I guess there's that value of experience of obviously the time that you've gone through this journey for people to lean on in terms of that kind of information and stuff, because I can appreciate any form of change in general practice is always a challenge, but having to go through that process not easy, and having a helpful voice to guide you along it can definitely be a positive experience and stuff. I know there's lots of questions about the
Yes.
Hello?
If you can go.
Sorry, I think we've got somebody jumping in on us, wherever they are.
And there's some posters in the surgery, and if you go on our website, it's actually on our website.
Sorry, whoever is speaking, I'm afraid you're kind of telling everybody about your Indeed job posting and stuff, so kind of guessing you don't want to do that. But if people do want to get access to the recording, so that will be available in the patient in the Practice Index forum and stuff. So that will be coming out to everybody and available to watch both the recordings from this. And I think there is a plan to collate a lot of the questions and put those into a separate blog as well, coming into the Practice Index forum as well. What would really help to get all that information is filling in the feedback. I know we mentioned it a couple of times, and the link to that is in the chat. So please click on that before you all head off and stuff, because I know we're coming up towards time and things. I wanted to thank both Joe and David for their time. We've kind of given them a grilling for the past hour or so in terms of how they've kind of started this system and how it's shaped up. And I appreciate we may not have been able to answer every question there, but I'm hoping we've covered the broad spectrum of most of the stuff people wanted to know about and things. And I guess obviously that there will be that further information provided by the practice index team in terms of capturing all that information for people if they want more details. And I'm sure if people want to go through this session again, that'll be something we can potentially look at coordinating in the near future and things. I guess from my perspective, what I would definitely recommend people consider, obviously the capacity and access improvement plans do need to be in within the next month or so. So this may be a system that can help to move those plans forward for you in terms of your own practice or network area. So maybe consider some of that aspect of stuff in terms of how that will look for you in your practice, because that is potential, I'm not going to say additional funding, but funding nonetheless that you can access if you do get those plans in time. Thank you everybody for joining us. I appreciate people may need to head off to back to practice and stuff, but as I said, the recordings will be available on the Practice Index forum. Thank you, Joe. Thank you, David. Thank you, everybody else.
Okay, thanks everyone. Bye.
Catch you all later, hopefully.
Thank you.
Wishing you all a great day.